Good afternoon again, everybody. I'm Dr. Stephanie Vanderpool. I am re-recording this webinar presentation for you today due to the technical difficulties we had during our live presentation. I thank you for your patience and I thank you for sticking with us to get this very important information. Let's get started. Before we do that, did you get a chance to watch our June webinar on targeted pain treatment? If not, it's available on the YouTube channel, Targeted Pain Treatment YouTube channel. You can click there to see that and other short videos about targeted pain treatment and how it can help you treat the source of your pain. So now let's talk about the number 50 million. That's the number of Americans that suffer from chronic pain on a daily basis. That's over 20% of the entire country. One of those patients is a patient of mine, Miss Barnes. You see a picture of a wheelchair here because that's what Miss Barnes used to have to use to do one of her pastimes, which was to go craft shopping. You see, Miss Barnes is an avid crafter, but when it was time for her to go get crafting supplies, she had to be pushed in a wheelchair because of how severe her back and leg pain was. Because of this, she wasn't able to enjoy her pastime or as much activity as she would like. So Miss Barnes came to see us. And over the course of her treatment, we did several different targeted injections to help her improve her function, treating the underlying source of her pain. The most recent procedure we did for her is called a spinal cord stimulator. And what that is going to be discussed a little bit later. But what we did was we were able to provide her with improvement in her function and quality of life so that she could get up and go to get her craft supplies without relying on a wheelchair anymore. In fact, she was able to walk the entire store just using a cane and maybe pressing on the shopping cart. She was ecstatic. You can actually watch her tell her own story in the portal as one of our supplemental patient videos. I hope you'll tune into that. So that brings us to what we're talking about today, which is injections and procedures. What, when, and why. A little bit about me. I'm your presenter today, and my name is Dr. Stephanie Vanderpool. I'm Assistant Professor of Anesthesiology at the University of Tennessee Medical Center. I'm also the Director of the Comprehensive Pain Service and the Medical Director for our Comprehensive Pain Center at the University Center for Pain Management. I'm a board-certified anesthesiologist and pain management specialist with over 10 years of specialty practice in pain management. In addition to being a physician, though, I'm also an educator. So I train, speak, and write on the topic of targeted pain treatment, in addition to founding a course on targeted pain treatment conference that we use to educate other colleagues around the state and the country on how to practice targeted pain treatment to provide this service to their patient. But most importantly, I feel like I'm an advocate in terms of raising awareness for and fighting for access to targeted pain treatment for our patients. I serve on the board of state and national organizations to accomplish just that. And I'm so glad to have the opportunity to present to you today on this very important topic of targeted pain treatment injections. So the purpose of today's presentation is to equip and empower persons with pain to find relief and improve their quality of life through targeted pain treatment, injections, and procedures. We want to accomplish 3 goals today. Number 1, raise awareness on the process of targeted pain treatment, injections, and procedures and how they can help with the pain. Number 2, we want to reduce fear because there's so many misconceptions about what these procedures entail and what it's like to experience them. And we want to address some of those today. And then number 3, we want to recommend action for you or your loved one if you're suffering with chronic pain. A few items of housekeeping. There was an opportunity for live Q&A after the presentation. Because I'm re-recording this for you, you'll get to see the Q&A that was live after the presentation, but you're also welcome to put questions in the chat and I'll do my best to pop back into the portal and answer them over the course of the next few days. We also used audience polls, but you can answer along as you watch this presentation and think about what your answer might have been as the questions go up. And then finally, we had exhibitors that were in our virtual exhibit hall, and we'll make sure that you have access to those exhibitors after the presentation. So the first question we asked is, how did you hear about today's webinar? Was it social media, newspaper, flyer, word of mouth, or other? In the live version of this, we had several people that responded newspaper versus flyer, but feel free to drop it in the chat if you're watching this recording and let us know how you heard about today's presentation. So the first point, remember we said we had 3 to address today, raising awareness on targeted pain procedures and injections. First, I want to talk about the targeted pain treatment approach. Targeted pain treatment is a process of accurately diagnosing the cause of pain and then targeting the treatment to the cause. By doing this, we're able to reduce opioid use while effectively treating pain and improving function. We call it the chronic pain solution. There are three core principles to targeted pain treatment. The first is to accurately diagnose the cause or causes of pain. You'll see a picture here of a car with a flat tire, and this kind of represents how pain can slow you down. The 4 tires on the car represent the 4 components of pain that can be present in a patient at any point in time. 4 causes, I would say. Physiologic causes are how the body processes pain signals. Anatomic causes are the structures in the body, such as muscles, bones, joints, and nerves, that can contribute to these pain signals. Functional causes, such as injury, posture, movement, or other position-related factors, can also be one of those flat tires for you. And then there are psychosocial causes, how the mind deals with emotions, stresses, environmental factors. All 4 of these are different causes of pain that can be present in a patient at the same time. You can imagine if you had 4 flat tires, but you only treated one of them, or only put air in one of them, you wouldn't be able to go very far very fast. So then we target the treatment to the cause by treating the source of the pain. And that's targeted pain treatment principle number 2. Using medications to treat the physiologic cause of pain. Interventions target the anatomic structures that are related to the pain. Physical therapy targets the functional limitations caused by the pain. And psychosocial therapy targets the psychosocial comorbidity associated with the pain. The goal is to really focus on function, to get you from being bogged down by that flat tire or flat tires, and to get you moving again with targeted pain treatment. Because this webinar is focused on interventions, I'm going to ask you again another question. And this time it's going to be, which of the following procedures have you heard of before? We've got epidural steroid injection, radiofrequency ablation, trigger point injection, spinal cord stimulation, sacroiliac joint injection, peripheral nerve block, or some or all of the above. If any of those kind of relate to you, go ahead and drop them in the chat within the portal, and we'll take a look and see what your answers are. We're going to talk about a few of these procedures, just highlight about 4 of them today. But I wanted to just go over the what, when, and why of each of these procedures, because I think it's important for you to understand the science behind it and the purpose behind doing these different procedures. The first one we're going to start with is trigger point injections. So trigger point injections are injection into the muscle that may have a knot within it that is causing persistent muscle spasm. When we do these injections, we're trying to release that muscle spasm because it has not been released by other conservative treatment options, such as NSAIDs or anti-inflammatory medications, or even massage or heat. These are knots that are persisting and causing ongoing pain that can sometimes even send patients to the emergency room because of how severe it is. The reason that the trigger point injections work is because it breaks up the actual underlying knot to release it so that the muscles move smoothly against each other instead of being bundled up in a knot. And that in turn gives you relief almost instantaneously. And you can sometimes have some post-procedural soreness for about 1 to 2 days, but overall, most patients feel very relieved after they have these particular procedures. The next procedure we're going to talk about is epidural steroid injections. Again, what these are injections into the space around the around the fluid around the spine, called the epidural space. And in that epidural space, there are several structures that can cause or precipitate a pain signal. You can have bulging discs, as you can see in the lower graphic there, that can press on the nerves in the middle of the spine. They can also press on the nerves that come out the sides of the spine that go down the legs or the arms. And they can also just overall cause back pain because of just inflammation up and down within the spinal column. So when we do these procedures is when a patient is experiencing pain from this type of pathology that's not responding again to conservative treatments such as physical therapy or other. The technique is often to use fluoroscopic guidance. That means we use an X-ray to see the bones within the spine and also where the needle is located to make sure we get that needle in the precise location it needs to go. You've got interlaminar epidural steroid injections. That's the picture at the top where we go in the middle. Or you can do transforaminal epidural steroid injections. That's that picture at the bottom, where we can go onto the side where those nerve roots are coming out and get one particular nerve root at a time. That can be very good for that precision nerve block that we need to do. In terms of the timeline, the relief usually takes 3 to 5 days because that's how long the steroid might take to work, but often continues to improve over 1 to 2 weeks. And depending on the underlying causes of pain, this procedure can last for months, even up to a year. Earlier this week, I saw a patient who was coming back for his repeat epidural steroid injection. His last one was done over a year ago. and he'd been doing great up until just a month ago. So it's possible for these injections to last a really long time if that's treating the cause of your pain, or if you don't have other causes that are also contributing to it. Next, we've got radiofrequency ablation. This is one of the more advanced procedures that we do, where we use targeted heat energy to burn the nerves that are coming across from specific joints in the spine or the legs to help reduce that constant pain signal that might be communicated. We often use these procedures when the pain from those joints is persistent despite other targeted treatment options, such as in the joint injections or physical therapy or medications. As you can see from this target example, we can do this in multiple locations within the spine, the sacrum, and even the knees for patients with persistent knee pain. The technique involves placing needles in a very precise location and then often testing those needles with a little bit of electrical energy to make sure we're only contacting the nerves that we want to burn. We do not want to contact any nerves that are providing any strength or any major sensation to that anatomic region. For example, we're not going to be doing a burn of a nerve that's allowing you to lift your foot or bend your knee. We're only burning the nerves that are communicating a persistent pain signal. The timeline for these injections is often a little bit longer than an epidural steroid injection. That's because we often have to do what's called test injections or diagnostic injections first. We want to make sure that before we commit to burning a nerve, that we're contacting the correct nerve. We don't want to burn a nerve that's not contributing to the pain signal. Once we've done the radiofrequency ablation, once we've done the test injections and identified the nerves that we want to burn, then we do the actual radiofrequency ablation procedure, where we heat that nerve very precisely after numbing it up so that that nerve is burned and it doesn't communicate that pain signal anymore. Relief usually takes 2 to 3 weeks for the nerve to completely die down after it's burned, and often the relief can last you up to 6 months or longer until the nerve grows back together again and grows over that scar tissue that was created. The fourth procedure we're going to talk about today is spinal cord stimulation. Spinal cord stimulation is generation or delivery of electrical energy to the actual spinal cord. These are not TENS units, but rather they are placed within or underneath the bones in the spine in the epidural space to send precisely programmed electrical energy to different parts of the spinal cord. What that does is it interrupts the way in which the pain processes the pain signals coming from the affected area up to the brain. So it basically neuromodulates or modulates that nerve transmission in a way that reduces your pain, again, without reducing your ability to function or your ability to walk or anything of that nature. It really is just treating the pain by changing the way the nerves process those signals. The technique uses fluoroscopic guidance to make sure that the needles are placed in a precise location and that the leads, those are the little black dots that you see on this middle picture, are located exactly where we want them to be, both in the middle of the spine and top to bottom, to make sure we're contacting the correct portion of the spinal cord. In terms of the timeline for spinal cord stimulation, there's an evaluation process which ensures that you're an appropriate candidate for that, both looking at your type of pain that you have, the types of procedures that you've tried and failed, and also making sure that there's a psychological evaluation that's done that's required by insurance to make sure you're an appropriate candidate for this procedure. Once we've done that, we'll put you through what's called a spinal cord stimulation trial. This is where we put in the leads into the epidural space, but attach them to an external battery pack that you wear around your waist for about a week. That allows you to see if a spinal cord stimulator will make a life-changing difference for you and improve your function and quality of life to be worth going to the next step. The next step is to implant the device surgically, similar to how patients might get a pacemaker implanted under the skin. Both the leads and the battery are implanted underneath the skin and can communicate to each other. Some of these devices are rechargeable, which means you can charge it through the skin, similar to how many of you may charge your cell phone by just putting it on a plate, a charging plate. Some of them don't require recharging and they just run continuously until the battery wears out after several years, similar again to pacemakers. And the other thing about these devices is that they are reprogrammable to help you maintain and keep relief, even if your pain pattern somewhat changes. I'm going to play a video for you now, and this is a patient of mine, Ms. Teresa Gain, and she's talking about her experience with ultrasound-guided trigger point injections. Take a listen. Thank you for joining us.
Oh, no problem.
So, Ms. Gain, I would like to just talk with you a little bit about your experience with targeted injections Specifically, the ultrasound guided targeted injections we do. And so, what is the pain like before you come in for your injection? What does that feel like for you?
It's almost like somebody has put a ball or something in my back, and it's I like knots. And I'm sitting there and I rub them, I put stuff on them, and it doesn't help. But coming in and having the trigger points, each trigger point that I have done in one of those knots relieves the pain right there immediately.
Wow.
And so when I leave the office, I'm totally out of pain.
So that's just an example of what one of our patients has experienced with her trigger point injections. And we have so many other patients who experience this with different types of procedures that give them their quality of life back. So remember the first point that we wanted to address in today's presentation was to raise awareness that targeted pain treatment injections treat the source of pain and can help improve function. Number two, what we wanted to address today was to reduce fear. So now I've got another poll question for you. Which of the following phrases have you heard or said before? Injections don't work. I'm afraid of needles. I'll just live with the pain. Some of the above or all of the above. Go ahead and drop your responses in the chat box and we'll take a look and get back to you on those. So something that I want to do to help you reduce your fear of targeted pain treatment injections is to talk about what we do to make sure we're treating the source of your pain. And that is that we want to be specific, strategic, and safe. When it comes to being specific, we want to have an accurate diagnosis. We want to target the anatomic source of pain as precisely as possible. What we don't want to do is be on the outsides of the anatomic source of pain. For example, you've got pain in your shoulder joint, but we're injecting a bursa on the outside of the shoulder or vice versa. We want to be, again, wherever that pain is coming from, that's what we want to inject. The other thing we're not going to do is just inject something blindly without knowing exactly what we're targeting. So you can guarantee that when you're coming to a targeted pain treatment practice, that we're going to be as precise and accurate as possible, as specific as possible in targeting the anatomic source of your pain. Next, we're going to talk about strategy. We've got two strategies that we apply when we're trying to treat the source of pain. The first strategy I refer to as worst pain first. Sometimes you can have multiple causes of pain, but one of them is just so much more intense than the others. Think, for example, is if you had a house that you were trying to repair the roof, but the kitchen was on fire. You're not going to get too far repairing the roof if you don't put out the fire in the kitchen. That's the same way it is sometimes with patients who have severe pain coming from one location when all the others are kind of moderate pain. Think, for example, somebody who has such severe pain in their buttock that they cannot sit down. They may have some aching back pain, but they cannot sit or stand. If I just treat their back pain and don't address their severe buttock pain that's preventing their quality of life from improving, they're not going to even notice any type of improvement. I've got to treat the worst pain first. The second strategy is starting from the inside out. Sometimes you can have multiple sources of pain that overlay each other. For example, there are bones and discs within the spine that could be contributing to some of your pain. Then you've got muscles on the outside of those bones and discs and nerves in between. And so the challenge is that if you just treated, for example, the muscle spasm, but didn't address the underlying bones and discs and nerves, it could be as though you were just trying to patch drywall over a roof that's leaking without actually fixing the leak behind the drywall. You just end up needing a bigger bucket because you keep leaking water out, right? That's why it's so important, if you've got that overlying pain where everything kind of hurts the same, that we start from the deepest structure and work our way out. The third S in the specific strategic safe rubric is safe. That means we want to be as accurate as possible with needle placement. We use image guidance such as fluoroscopy or ultrasound to make sure that our needles go exactly where we want them and as safely as possible. So here you're going to see a patient injection experience within the practice. Starting off with filling off some pre-procedure paperwork just to make sure that we've got our checklist in order and make sure nothing has changed from the last time you've been in. Walk you back to the procedure room. Once in here, we'll check your pre-procedure vitals to make sure that everything is just as we'd expect, blood pressure and heart rate. It's okay to be a little bit nervous. Sometimes those blood pressures could be a little high. And then the physician will come in and speak with you before the procedure. make sure nothing has changed.
Hello.
Hey.
How we doing?
A little nervous, but I'm good.
It's understandable. You know, it's normal to be nervous when you have these procedures, but you've been through this before, you're going to be just fine.
Once all your questions have been answered, we'll get you positioned on the X-ray table. Clean off the area that we're going to be working on with sterile solution to make sure that we minimize any potential risk of infection. And then using an X-ray machine, carefully place the needles into the target area. Once we're satisfied with the needle position in one view with the X-ray, we'll check it again in another view just to make sure we're at the correct depth, taking our time to make sure the needle tip ends up exactly where we want it. And then from there, put a little Band-Aid on you, stitch you up, and then you're able to walk out and go on about your day. So I hope that that video and the slides that preceded it would help to reduce some fear about what we do to make sure our injections are specific, strategic, and most importantly, safe for our patients. So our third point that we're addressing today is recommending action. I'm going to review this slide again because I think it's important to understand the ABCDs of pain advocacy. The first is to ask questions. What's causing my pain and what can be done about it? The second is to be optimistic and open to treatment options. It may be that targeted injections may be appropriate for you, and it may be that they're not even necessary because there may be other treatment options available to you. You want to clarify the plan wherever you are and make sure you understand why we're doing the injections we're doing. And finally, you want to do your part to focus on function, whether that means participating in physical therapy before or after the procedures to make sure that your function improves as rapidly and as much as possible. Here at the University Center for Pain Management in Knoxville, we're here to help. I'm highlighting our team here, which consists of both myself and Dr. Jonathan McBride, who's both of us are board certified in both anesthesiology and pain medicine. We also have two awesome pain management nurse practitioners, Audrey Wall and George Mears, both of who are essential to our team to help us diagnose and treat and maintain our patients and their function and quality of life. And of course, we could not do this without our amazing staff of medical assistants, front desk, specimen collectors, and everybody else that helps participate and help our patients get the relief that they need. We've got some resources for patients. Specifically, there are some websites and online resources you can go to. UTmedicalcenter.org has lots of resources for patients within the East Tennessee region. And then UCPMK.com is the website for the University Center for Pain Management of Knoxville, where you can request appointments or request a referral to see us. And then we also want to encourage you to check out the Targeted Pain Treatment YouTube channel that has more videos and information on targeted pain treatment. For clinicians, we have the Targeted Pain Treatment Toolkit, which you can find at www.tpt-toolkit.com. And also, I want to make sure that you save the date for the upcoming 4th Annual Targeted Pain Treatment Conference. This is a conference for medical professionals, from physicians, nurse practitioners, pharmacists, anybody who's a healthcare provider that wants to learn more about treating the source of pain as precisely as possible. And you'll be able to find more information soon at that tpt-toolkit.com site. But for right now, save the date, February 18th, 2022. Right now, we're planning for it to be live, COVID permitting. And we hope that you can join us if it's something that's of interest to you. Now, what you can do today, you can schedule an appointment. You can call your clinician and schedule an appointment to discuss your pain and how it's affecting your function. You can also encourage your clinician to check out www.tpt-toolkit.com for tools and resources about targeted pain treatment. And finally, you can subscribe to the Targeted Pain Treatment YouTube channel for updated videos on how TPT can help you or your loved one enjoy life not limited by pain. Finally, I want to end with this patient video, which is another patient of mine, Ms. White, telling patients what she thinks they need to know about targeted pain injections. Listeners or viewers to know about these injections, targeted injections, or just targeted pain treatment in general that you either would like people to know or wish you knew before you came to see us?
I think people should not listen to their neighbors and people that haven't even ever had it done, of all the horror stories of how big the needle is and how bad it hurts, and all these nightmarish experiences that other people have had. Come for a consultation yourself and have someone that is a trained professional explain it to you, and you will see that it's not like what you heard from your step neighbor-in-law down the street, because it's probably not going to be accurate, because I heard those stories too, and those go around of how big the needle is, and how painful you are after it's over, and that kind of thing, and it's just not the truth.
Listeners or viewers. So finally, our final audience poll is, what are you going to do to help to treat the cause of your pain? Are you going to do nothing and just live with it? Are you going to make an appointment with your primary care provider to discuss referral to a pain specialist? Are you going to check out the TPT YouTube channel? Or are you going to listen to your step neighbor-in-law and not do anything about it? I want to thank you for taking the time to review this recording for the Targeted Pain Treatment webinar. I also want to give a special thanks to the generous donations to the Targeted Pain Treatment Outreach and Education Fund that made this webinar and this recording possible. I'll be checking into the portal periodically to answer questions, and we're going to play the live Q&A after this video so that you can see some of the answers to the questions. And again, I'll be answering questions on the portal throughout the next couple of weeks. Thanks again for your attention. Take care. George, welcome.
Thank you. I'm glad to finally see us. Yeah, we do have a number of questions that were presented before this session, and I'm glad we've been able to have those. One of the consistent questions that we've had is, with the injections, how long will it take before I can expect relief, and how long will it last?
So with the injections, it depends on what type of pain you have and what type of sources of pain you have. I like to use the analogy that recently came to me, but I like to use the analogy of having a boat with a little bit of water in the hull. So if any of you are boating individuals, sometimes there's this thing called a bilge pump that allows you to pump out water out of the bottom of the boat. But sometimes it malfunctions and you get a little bit more water in the bottom of the boat than you would like. Sometimes you've got to bail a few times in order to get to the bilge pump and figure out what's wrong with it. And sometimes you can just get right in there and turn it back on again and have it working. So really what that means is that your body is going to tell us how many injections it is that you need based on the number of different sources of pain you have or how much water is in the bottom of the boat.
Now, another question that kind of lends itself to that, there are questions about how frequently will I need treatments? Is there any therapy available that's permanent?
So again, that all depends on the number and types of causes of your pain. So if you've got multiple causes of pain, it's possible that we can address many of them in close succession and then get it to the point where you can do physical therapy to improve your function. Permanent treatment can be challenging depending on, again, what's causing your pain. But if we can get you to where your function is back to where you want it, to where you can go on your 12-mile hikes or where you can enjoy life without being limited by your pain, we consider that to be a win. And I hope you would too.
Absolutely. Absolutely. There's another question. For certain patients who've had some benefit of symptoms with medications, if you're having injections, does that preclude you from being able to continue medications that are helpful?
So if your medications are helping, and very importantly, if they're treating the cause of pain, so we're not just talking about opioids, but we're talking about medications such as muscle relaxers or nerve pain medications, and they're still necessary even after we've done the targeted procedures, then yes, as long as we're treating all of those causes of pain, remember we talked about those 4 flat tires, that's something that we can continue. Doesn't mean that it has to be continued at exactly the same dose. It may be that you don't need that dose anymore. So we'll address and adjust it as needed.
Okay. And we are getting some questions that were presented to by the panel earlier. What are your thoughts on PRP and prolotherapy?
So PRP and prolotherapy has been around for several years, and the evidence continues to evolve. At present, I don't have as much of an understanding of it that I would like to be able to speak intelligently about that topic. But I would say that you can do your research, speak to a specialist that does specialize in PRP and prolotherapy and get that data from them so that you can find out if it's something that might be appropriate for you.
Okay. Another one, for those patients who have significant procedural anxiety, there was a question about, is sedation available for these injections?
So sedation can be available for the injections, either oral sedation or IV sedation. But what that depends on largely is what your insurance will cover. So while there are opportunities or there's access to monitored anesthetic care and oral sedation at University of Tennessee Medical Center, some insurance companies do not pay for sedation for these types of procedures. So we work with you with your procedural anxiety. We'll talk through what we need to do so that we can make sure that your procedural experience is as painless and as anti-anxiety provoking as possible.
Right. And that the same attendee presented a companion question. Are these procedures offered as an in-office procedure or as a hospital outpatient procedure?
Very good question. So many of the procedures we do can be done in either location. We do have an in-office fluoroscopy suite and in-office ultrasound. Remember, those are those two bits of equipment that I mentioned that allow us to see our needle placement and be as targeted as possible and accurate as possible with our needle placement. We also do several procedures downstairs in the outpatient hospital department of UT Day Surgery. And those are often either more advanced procedures or procedures that require special equipment. Sometimes we'll do what we call bread and butter procedures down there also, but it's a conversation you can have with your clinician and a conversation that often has to include your insurance, unfortunately, too.
Okay. Another new question, and I don't know if this was addressed previously, but is there a limit to the number of injections or treatments you can have in a year?
So there's not a limit to the number of injections, but what we can say is that there are limits in terms of being safe with the amount of steroid that you get in a year. So we try to limit the amount of steroid to what's best for you. The amount that's quoted is often 240 milligrams of steroid equivalent, such as a medication such as triamcinolone, which can equate to about 3 to 4 injections a year. That said, some of the injections may not need steroids, such as trigger point injections or diagnostic blocks. And because of that, it's not that it's a certain number of injections you can have per year, but more so making sure that we're treating the cause. Another thing to mention is that some insurance companies do limit the number of injections of a specific type that you can have a year. For example, it's very common for insurance companies to limit radiofrequency ablations to only 2 a year. But we will discuss all of that with you when you come to see us if it's a procedure that you need.
So we have several versions of the same question. Could these procedures make my pain worse?
So ideally, we would love to say that it would not make your pain worse, but there may be situations that are not yet diagnosed that could potentially be aggravated, such as a temporary increase in muscle spasm or a temporary increase in pressure on a nerve root that could cause you to feel more intense pain for a brief period of time. There have been some patients, and it occurs sometimes, where the muscle spasm can be so intense that feels like it's a brand new pain, but it can be treated with either medications or a trigger point injection or something to release that actual muscle spasm. But ideally, if we're doing our job to diagnose the underlying cause of pain and then recommending the correct procedure for that particular cause, it should not get worse.
So a question, I suppose this is regarding the procedures, but there was a question about what medications will be used.
For the procedure itself, it depends on what we're targeting. So if we're doing just a diagnostic injection, that often only uses local anesthetic, which means it's a numbing medicine that just blocks the nerve conduction. However, sometimes we use a steroid also, which is an anti-inflammatory medication that reduces inflammation where it's injected. Those are typically the types of medications that we'll inject for targeted procedures.
And many of these questions, kind of revolve around concern of side effects. One that has come in is, are there long-term side effects or negative consequences of these therapies?
Long-term side effects, that's an interesting question. So part of what we do when we're talking about being specific, strategic, and safe is making sure that we're not, for example, over-injecting steroid to a particular area, or we're not causing nerve damage of some sort because we weren't in the correct location with the particular needle or procedure. So ideally, the long-term side effects, if there were any, would be minimal. Negative side effects would be minimal from any type of procedure. And it's honestly not something, and George, you can chime in too, it's not something that we typically see in our follow-ups, patients complaining of anything long-term on a typical basis.
Absolutely. I've enjoyed working with the patients with this office because we consistently see patients having improved symptoms, improved function, and that builds. You've done a profile before on a patient who had extensive pathological issues with their spine, and he has achieved a level of function that he didn't think would be possible. And so we have several success stories like that.
Wonderful. Well, at this point, I think we want to respect everybody's time. Again, I wanted to thank you all for your patience and with our technical difficulties at the beginning of this webinar, and appreciate your interest. The webinar recording will be available on the portal for 30 days, as will the supplemental videos that are currently in the supplemental videos section. Please do engage with our sponsors that were kind enough to help support this webinar. And I thank you again for your attention. Look forward to seeing you next time. Bye-bye.